Hello and welcome, everyone. It's really a pleasure to have you, all of us, for this virtual dialogue. And I'm Shalini Jaishekhar-Zure, and I'm a Senior Advocacy Manager with the Union for International Cancer Control. And here I'd also like to take a moment to mention that this special focus dialogue was possible thanks to support from Diagnostics. So before we get started, I'd like to introduce the topic. Early diagnosis of cancer focuses on detecting symptomatic patients as early as possible, so these patients have a better chance with treatment. When care is delayed or inaccessible, chances of survival are affected. Treatment could become more complex, and you also have higher costs of care to patients and the health system. So early diagnosis improves cancer outcomes by providing care at the earliest stage, and it's therefore an important public health strategy in all settings. The coronavirus pandemic has triggered a rapid transformation of health systems and the provision of care on a global level, which is unfortunately still ongoing. This pandemic has also significantly shifted the way cancer patients are being diagnosed and treated. On the one hand, services are restricted, and on the other hand, patients are hesitant to seek treatment. So it's important to acknowledge the challenges this pandemic poses on early and accurate diagnosis, and to also have a discussion on approaches that could address these issues in both high, middle, and low-income settings. So in order to discuss these issues in more detail, I'm very happy to welcome three expert panelists who will share their experiences, highlight some of the challenges, and talk about how these challenges can be addressed, and also next steps to ensure a smooth way forward. Our first speaker is Suzanne, who is the Chief Precision Officer with Diagnostics. Suzanne is responsible for leading the knowledge and insights team of experts in Diagnostics. Her role includes Her role includes helping Diagnostics clients understand the critical relationship and dependency between testing and treatment, and ultimately think precision medicine into corporate strategies and tactical plans. She also has a broad commercial experience in molecular pathology, where she has led several global launches of companion diagnostic products. Suzanne will start off our discussion on the challenges in the diagnostic testing ecosystem post-COVID-19 and also address next steps. Suzanne, please go ahead.
Thank you very much, Shalini, and thank you so much for giving me the opportunity to share some of Diagnostics insights and views on the challenges within diagnostic testing and how COVID-19 have impacted that. If we go to the next slide, please. So to set the scene of the dynamics at play in delivery of test-dependent precision medicine therapies, I'm going to be using US and testing within non-small cell lung cancer as the basis throughout my slides. We do see some variations across geographical regions and within different tumor types in oncology, but the trends are fairly similar. And NSCLC represents a good analog as it demonstrates the complex dynamics and some of the challenges within precision medicines. And a couple of the dynamics that I'm going to address in the presentation relates to the delayed diagnosis of patients, the rapid increase in new precision treatments, as well as our continued better understanding of the disease, and also the fragmented stakeholders and imperfect information that flows combined with a lack of standard approach to precision testing within patients. If you go to the next slide, fortunately, we are seeing great advances in precision medicine and the care of patients. And just within the last 2 decades, we've seen FDA approve 12 new targeted drugs within lung cancer, both first and second line treatment. And that have led to a stunning 48% reduction in disease progression. On the testing aspects, we've seen a shift towards biomarker testing using more advanced technologies. So for example, next generation sequencing is allowing for a broader genetic profiling of patients. And also the increased use of liquid biopsies is enabling testing of patients who actually might otherwise miss out on treatment due to tumor sampling difficulties. On the biomarker side, there's no doubt that the introduction of immunotherapy and the biomarkers linked to that have been a game changer. And we've seen that PD-L1 testing in this space have had a very rapid adoption compared to standard. And today, around half of the oncologists are testing their NSCLC patients for PD-L1, which is actually quite amazing. But there are also challenges, and on the next slide, if we can turn to that. When analyzing the US non-small cell lung cancer landscape, it reveals some real challenges in the clinical diagnostic testing ecosystem. In 2018, around 40% of the FDA approvals were actually within precision medicine, but we also see that the uptake of the biomarker is around 4 to 5 years, which leaves a significant delay for patients to get benefits from these treatments. On the financial model, there is a fundamental challenge with the precision medicine testing and the diagnostic aspect representing only around 2% of the revenue, but contributing much higher value to the ecosystem. And studies have shown that the vast majority of the educational investment relates to testing, or that the investment that relates to testing goes into the late predictive phase of the biomarker. So not focusing on getting patients early diagnosed. And as a consequence of this, we see the effect in the testing ecosystem, and approximately 50% of the patients are not receiving the appropriate treatment, and the majority within NSCLC patients will be diagnosed at late stage and not having the opportunity to benefit from second or third line treatments. There are several hurdles in this, and if we turn to the next slide, please. With working within the precision medicine space for years, we've seen some fairly common hurdles contributing to a broken diagnostic ecosystem. And time today will not allow us to go into a deep analysis of the different hurdles, but just to address some of the common pain points. We see that there is a lack of alignment between stakeholders through multidisciplinary practices and insufficient focus on early diagnosis. We also recognize that we need more standardized and harmonized approach to adding biomarker testing into guidelines and into the patient pathways. And there generally is a need for more support of the laboratories, including that of education and adequate funding to secure higher quality of testing and better regulatory support. So if we turn into what impact COVID-19 had to this, and if you go to the next slide, please. So obviously, COVID-19 have affected the ecosystem, and it's not surprising that we've seen a decrease in cancer patients being tested. In the US, we saw between February and March of this year, we saw a 31% drop, and it's still below average of what we would normally expect of testing rates. We saw the same in China, just to mention another country where there was a 40% drop in testing in that same time period. But interestingly, the decrease in testing was less related to test capacity being challenged by focus on COVID-19. It was more related to the decrease in patients presenting and being diagnosed at an early stage. So the trend, if you go to the next slide, please. The trend seen for non-small cell lung cancer is fairly similar across tumor types and also across multiple biomarkers that we would expect to see performed on these different diseases. So I've illustrated it here with CRC and AML in addition to the non-small cell lung cancer. And recent studies I've seen and speculations are that there will be a 5-year negative impact on the outcome of patients relating back to the consequences of the dip in testing that we are seeing now. So to wrap up my part of the presentation, if you go to the next slide, please. Looking beyond COVID-19 and starting to improve on the diagnostic ecosystem for the benefit of patients really takes a collaborative approach. It is key that the effort happens across multiple stakeholders. And we need to start focusing much earlier in the pathway already at biomarker discovery and design broader system solutions across all systems. And to drive the right solution, it's key having real-world lab data available and supporting labs globally. Improving test quality will require really an enhanced training, technical, and regulatory support. We believe that every patient should get the precision medicine they deserve, and that's kind of the ethos that's been driving Diagnostics. We have recently introduced what our platform called the DXRX, which is the world's first diagnostic network. And this platform is to offer transparency and enable that better collaboration across stakeholders. So we've worked to secure better treatment by better testing for the last 15 years, and we'll continue on this journey together with labs, diagnostic companies, and pharmaceutical companies within the precision medicine space. And that's the only way to really benefit patients globally. So I'll wrap up my introduction there and allow for the other speakers to come in and present as well.
Great. Thank you very much, Suzanne, for that clear picture on the challenges in the clinical diagnostic testing pathway using lung cancer as an example, and also the negative impact of the pandemic on detecting new cases and for highlighting possible solutions, which I hope we'll discuss further. Our next speaker is Jody, who is Senior Vice President with the Prevent Cancer Foundation, and her portfolio at the foundation includes management and strategic planning. She has over 25 years of experience in leadership roles in the healthcare sector, including 10 years in healthcare management consulting and 15 years in the nonprofit sector. Jody's perspective will be on addressing the challenges of early detection before even reaching the actual diagnostic phase. Please go ahead, Jody.
Hello, everyone. Thank you for having me, and it's wonderful to be here. Next slide, please. And I want to thank my colleagues on the panel today for recognizing the importance of bringing in that discussion about cancer prevention and early detection from the patient or public perspective as we think about this challenge. Unfortunately, the prevention and cancer screening or early detection perspective is often left out of the conversation, and it's approved over time. But the Prevent Cancer Foundation was founded 35 years ago to address that enormous gap. We do our work through research, education, outreach, and advocacy, and we've really been operationalizing on all 4 pillars to address the aspects and the impact of COVID-19. Next slide, please. So we know that pre-pandemic, 1.8 million people in the United States alone are being diagnosed with cancer, with over 600,000 people dying from those diseases. Now what's happening is people are missing their routine cancer screening appointments and their routine vaccinations like the HPV vaccine, which we know can prevent certain types of cancer. People are also struggling with maintaining healthy behaviors. Smoking cessation has become a real challenge. Healthy diets have become a real challenge. There's many reasons why this is happening, but what we know is that there will be an increase in preventable cancer deaths over time. Next slide, please. So Suzanne talked a little bit about this in her presentation, but there was an enormous decrease in cancer screening appointments during the spring. This data is for the United States alone, but we do know from a World Health Organization survey done in August that disruptions to essential health care were felt across the globe. And lower and middle income countries reported even a higher or greater disruptions than high income countries. And also, as Suzanne mentioned, on the testing side, what we are also seeing in the screening side is that those rates are starting, the cancer screening rates are starting to approach pre-pandemic levels again. The concern there is that those numbers should be much higher now because there are so many people that missed appointments. Getting back to average is not really good enough. And lung cancer is lagging behind all the other cancer screenings in terms of returning to average. You know, it's important to consider that thanks to the work of many of the organizations and people on this call, cancer screening rates have continued to improve over time, but they're still not where they should be. So lung cancer screening rates, for example, are less than 5% of the eligible population receives lung cancer screening. That is pre-pandemic. So any even marginal decrease in those lung cancer screening rates is going to have an enormous impact downstream on patient success and survival. Next slide, please. So in order to adequately address and create our messaging to the public and to patients, we wanted to better understand why people were missing appointments even after healthcare providers started to resume their routine services. So, and they're still missing those appointments even now. So the top two reasons cited were fear of COVID exposure and that people are waiting for their provider to reach out to them to reschedule those appointments. With, you know, and this is just people who had an appointment already scheduled and missed it. This doesn't include people that should have scheduled a new appointment during that time. So it's likely that these numbers would be much higher if that population was included. We are updating that survey to include all those data points, and we should have that ready very shortly. But the bottom line, and to keep in mind, is people are scared. People are scared to go into the healthcare setting, and that outreach is critical right now. And recognizing that addressing trust and fear issues, as well as significant healthcare provider bandwidth issues, recognizing that's a big challenge, I wanted to provide a few examples of how you can leverage community and technology to address the challenges. Next slide, please. So it's important to reach people where they are right now, and to do that through trusted communities. Churches and faith-based organizations can be great partners in getting out the message, as can online communities. People are spending more time than ever online. An example is the Prevent Cancer Foundation is very fortunate to have a partner with the Games Done Quick. Games Done Quick is a group that has hundreds of thousands of people around the world watching their online gaming events. And it's a very collaborative group, lots of dialogue and chat happening, and it's a very close community. That community is able to provide us information about what's important to them, what barriers they're facing, what challenges they have, which we can use then to update our materials and provide helpful education and information. But it's important to keep in mind that you do want to invite community leaders and partners into your process. So include them as advisors into your process, and not just expect them to hand out or share information you've already created. It really needs to be specific to the community and keep that community's interests in mind. Next slide, please. So an example of leveraging technology, how we are facing travel bans and travel barriers. And one way that MD Anderson Cancer Center has used technology is through Project ECHO, or the ECHO model. The ECHO model connects groups of community providers across the world with specialists at centers of excellence in real-time online collaborative sessions. And MD Anderson has used that model to hold cervical cancer screening training, as well as case review in medically underserved areas of Texas and Mozambique. And if you're interested in checking out a telehealth session, they do have open sessions that you can see and register for by going to the Project ECHO website. Next slide, please. Another example of meeting people where they are is Eyebreast. So Eyebreast is a small handheld device that can be used anywhere to detect early signs of breast cancer. And researchers at Memorial Sloan Kettering have used, or very successfully, held a clinical trial to test the effectiveness of Eyebreast in Nigeria. And what they found is that they were able to reach never before screened populations, as well as receive really positive feedback from the community that they were working in. So these are just a few examples, and I would love to hear more about what you're seeing or what you're doing in the chat. Thank you very much.
Thank you, Jody. Thank you very much. And thank you for highlighting the current impact on screening services, and also for raising the point on how patients are hesitant to seek care and how we can leverage outreach with community-based organizations and also technology to help address this decrease in screening. Thank you. Our third speaker is Dan, who is the Chief Medical Officer with the American Society for Clinical Pathology. Before joining ASCP, Dan spent 11 years at Harvard, where he taught pathology, microbiology, and infectious diseases. Dan began working in Africa in '97 as a medical student, and has built an international reputation as an expert in cerebral malaria. In parallel with this, he has been heavily involved in pathology capacity building in many countries, and most notably led the team that built a pathology lab in Rwanda and Haiti for advanced cancer diagnostics. Dan will also talk about the challenges in the diagnostic testing ecosystem post-COVID-19, but from an LMIC perspective. Dan, please go ahead.
Thank you so much, Shalini, and thank you to UICC for this opportunity, and to my co-panelists for already setting the stage in the US and in prevention. Next slide, please. So if we step back to March and look at the global laboratory response to COVID, there were kind of two phases. And that first phase, in the initial phase, LMICs were waiting for guidance. And we largely, a lot of us were in the US and Europe, et cetera, waiting for guidance from WHO, from CDC, and that guidance was very slow to come relative to prior pandemics. And therefore, governments and LMICs enacted restrictions before testing was even available, or other processes before testing was available. They really jumped on this disease very quickly with non-testing related activities. So what did they do initially? They did receive some ration supplies for testing. ASCP was involved with some of that work. They received partial orders for testing workflow. They didn't receive everything they needed, but some of it. And why was this? Why weren't they receiving test kits and testing just like everyone else? Well, the answer is market priorities and low incidence of disease. However, this created real challenges in these settings because of pandemic pressure. The infrastructure was already fragile to begin with, so now it's strained even further. I'm talking about the entire healthcare infrastructure. There was pressure on governments to act in these nations. People were hearing stories on the news or on Facebook or on social media, et cetera, about horrible things are happening in China and America and Europe, and so the government needs to do something, so the government had to act. There was demand for testing platforms in countries that didn't have specimen transport networks, tracking of patients, or logistical efficiency. So you can't place a $150,000, $250,000 piece of equipment that can do 5,000 tests a day in a country that normally tests 100 samples a day in that lab, because they don't have a network to get it there, or they don't have networks that are enabled to get it there. And then there was the decimation of a fragile economy through restrictions on movement and travel. These are agrarian economies, these are trade-based economies. And when you suddenly say, don't leave your house, how do you get food? How do you do any kind of exchange for money? So the initial response to COVID had a fracturing, damaging effect on these economies overall, and the healthcare system was a sort of a parallel or peripheral collateral damage, if you will. Next slide. So we did a survey in March, right after COVID started, to quickly ask 53 laboratories in 10 countries that we were affiliated with, do you currently have COVID testing available? And more than half said no, they did not. Less than half, 40%, did have testing available at that time. And then, are you seeing or hearing about clinical cases that it could be consistent with COVID? And the answer, 80%, was yes. So there was clearly a need in March for testing to understand where the epidemiology was, if there were real cases, et cetera. But that was simply not available. Next slide. If we flash forward to October 2020, just last month, we now see a completely different picture. The African Development Bank, for example, in Malawi, has given them $45 million. That was out of a total of about $11 billion that was given to multiple countries for COVID preparation. And you can see on the left all these different countries with different test statistics. So Rwanda can do 10,000 tests a day as of July. Uganda is doing has done a total of 264,000 tests. Madagascar has 304 confirmed cases, et cetera. And note that South Africa has done 3.7 million tests. And the difference between all of those countries in South Africa is economy and economic development. And where there was a market and there were laboratories in existence and infrastructure, more tests were done. But there is, at this point in October, about a month ago, clearly an influx of money, and there is infrastructure to do this testing. However, if we look at that relative to, say, the US or Europe, this kind of response was available in May or April. So we're still very much delayed relative to the high-income countries. Next slide. So, but let's look at the global numbers of incidence, right? So incidence of disease, and this is as of October, and this is the ongoing daily rate from Johns Hopkins. And what you can see is that the incidence rates across all of these countries, the worst case scenario is about 73 per 100,000, which is equivalent to the worst case scenario of cervical cancer incidence, by the way. And the lowest rate is about 0.85 per 100,000. And the range is across there. And we would say that that's not a very high incidence disease. It's clearly something we need to pay attention to, but it's not a high incidence disease. And if we compare that with South Africa, which has 1,146 per 100,000, or the US with more than 2,500 per 100,000, we have to ask the question, is this a response to, is this a product of testing, or is this a product of true disease? And this is a question that we can't answer right now, and we do need data to understand that, and hopefully epidemiologically we'll be able to answer that question eventually. But we do know that with these low incidence rates, these countries are not having ICUs filled, fortunately, because they don't have ICUs in a lot of places, but more importantly, the mortality rates are not there, et cetera. So these incidents do seem to be relative to real disease, but at what cost did this come to the country? And that's what I want to show you on the next slide. So let's look at the impact on diagnostics from COVID-19 in these countries. So in our follow-up survey, 57% of laboratories reported effects on their other laboratory services, not COVID testing, but anatomic pathology, for example. So just like we saw in the US, surgeries were canceled, medical staff are infected, other medical staff are afraid to work, patients are afraid to go to the hospital, there were hospitals that were switched to be purely COVID-19 hospitals. Even with those incidences, there were hospitals that were switched over to just take care of one disease. The cost of labs increased because the volume decreased, and there were massive losses of revenue related to these testing for these hospitals. There are further delays in the supply chain that were occurring that was already fragile and fragmented, and performing postmortems occurred without proper PEE or clinical data. Around 80 to 90% of the incoming volume for both cytology and biopsy specimens, which is the hallmark of cancer diagnosis, were reduced. So that is 57%, so almost 60%, more than half of labs had this problem in a setting where COVID, we could arguably say, was not really a major problem for the health population. It was a problem for the government. It was a problem for the healthcare system to enact all of those things, but the effect on the population was a fairly low incidence relative to what we see in other countries. But in the same survey, more than 90% reported they had adequate hand sanitizer and cleaning supplies, and more than 85% were required to wear masks to work, beginning as early as March. So clearly, this response to COVID was strong and it was effective. We think the incidence is low, but it had a massive impact on these other services that are crucial for cancer. Next slide. So let's just look at two examples of how this impact is so crucial in LMICs versus HMICs. And for those of you who understand the stock market or anything about stocks, if we think about beta, beta is how much the stock market affects your stock. So if we think about that, how much the stock market affects your stock price, at a beta of 1, if the stock market goes up, your stock goes up about the same. Could we please mute that person who's speaking? But if you have a beta of 2, when the stock market goes up 1, your stock goes up twice. If the stock market goes down 1, your stock goes down twice. So we can think about LMICs and their healthcare infrastructure when we have a pandemic of having a beta of 10. So when the US has a little dip, as Jody and Suzanne showed us, in prevention or in screening that kind of returns to normal in 2 months, that dip is 10 to 20-fold in an LMIC and takes 6 to 8 months or even longer to recover to the same point. So it's just a much more impact, and that's because of that fragile infrastructure. So in cervical cancer and prostate cancer, they have the highest incidence in mortality in developing nations. This was prior to COVID. This is related to HIV positivity, low income, poverty, as well as Black African origin, with the highest rate, for example, of prostate cancer in the world in Dominica, an island that only has 70,000 inhabitants. There's no infrastructure for screening prior to 2018 when the WHO program for cervical cancer was launched. Let's make that very clear. There was no mandate from the WHO prior to 2018 that everyone should be screened for cervical cancer in Africa. Sure, their health systems were saying there were lots of data to support that this was important, but the WHO had not yet launched the cervical cancer program. So now there are blossoming cancer programs that begin in 2010 and 2015 in LMICs that were in anticipation of the WHO's announcements about these different cancers. And HIV testing and treatment, which is tied to cervical cancer screening, has been happening through PEPFAR even for the last several years, which is a wonderful triumph for those programs. The Bush Institute, for example, received $90 million from 2018 to 2020 for cervical cancer screening in HIV positive women in 10 countries, an amazingly impactful program that has started to save lives. However, with the advent of COVID, all these programs just stopped, because as we saw, hospitals switched over purely to COVID, patients were afraid to go, et cetera. So whereas we had percent reductions in the US, we went to 0 in most of these countries for a very protracted period of time. Next slide. And then if we look overall at incidence, which is above, and mortality, which is the below, in the US and Australia, skin cancer and access to screening and diagnostics overestimate the impacts of cancer relative to other countries. And a population of about 1 million people will have on average about 5,000 cancers per year, with that range being 4,500 to 5,500. So if you are diagnosed in an LMIC, you're much more likely to die, about 75%, than if you are in the US. And that does depend on you being diagnosed. So lack of infrastructure for screening and prevention, diagnosis, and treatment underestimates the burden of cancer in LMICs. So even before COVID happened, when we talk about the statistics from LMICs, those are estimates. They're not accurate. We know that likely the burden is much higher than what we can say, but we have to work with the data that we have. However, with the advent of COVID, what programs were functioning, as I mentioned, have ceased. as all healthcare workers, were task shifted to COVID preparedness. So this is no biopsies, no treatments, no surgeries. And so what little progress had been made, again, had been essentially silenced. And so if we think about the overall impact of COVID in a high income country versus a low middle income country or a low income country, the point is this exaggerated or amplified effect due to that. Notice, however, in the data that I showed you that the response to COVID was great. The incidence has been low and it has not ravaged that population. And there's been a lot of money poured into it to do that. But if we think about a tempered response where there had been more guidance, if the money had been spent in a different way or had been distributed more effectively, we probably wouldn't have seen the changes that we did to the cancer programs. But more importantly, we have to step back and ask the question, why are we pouring $11 billion into a disease which is hardly incident on the continent when we have diseases like cancer, which are not getting any funding, that are suddenly being bushwhacked by this disease and not really returning to a point where they can be treated effectively. So I think from the overall perspective of ASCP and the work that we do, COVID did massively inhibit our ability to travel to Africa, to send people to do training, to help with our capacity building. But we have continued to do virtual trainings online. We've run 2 virtual courses for a total of about 400 participants in pathology to help with diagnostics. And we have continued to deploy equipment, including telepathology, to connect pathologists to diagnostics. And the good news is, as of about August, oncology programs were reopening. It was much more delayed than we saw in the US, but are still not quite back to normal where they need to be, but we continue to support them to do that. Next slide. Yeah, thank you.
Thank you, Dan. Thank you very much for providing that really good insight into how the pandemic is causing pressure on an already fragile health infrastructure and also on a strained economy. Thank you very much, all of you. Thank you very much for your interventions. So before we start our discussion, I'd like to encourage and remind our audience to please send more questions through the chat box, and I'll read them out for you. Or please, if you feel like it, just let me know, and I think I can unmute you, or Martha can unmute you, and you can present your question and also talk about your experiences as well in your local setting. So before we start our discussion, as I mentioned, I'd like to ask our panelists a question. This is the question. So there are many challenges that need to be addressed to ensure access to diagnostic testing. And you actually covered several in your intervention. Could you please pick one and elaborate more on possible solutions and next steps to address this? Jody, if I may start with you. You mentioned in your presentation the need for continuous transfer of knowledge, training, etc. Would you like to elaborate on that?
Sure, I'd love to. Thank you. So we want to make sure that even though travel has stopped, and to be quite fair, people are exhausted. So that's both people working in the healthcare provider setting and outside of that. So everyday public people are very challenged to take on anything new right now. But we do have to continue transfer of knowledge and training, because there is so much new innovation happening, both within COVID and outside of COVID. As Dan mentioned, we can't forget that cancer is still an enormously important topic that has gotten left behind during this pandemic, and we have to keep up with what's happening and keep innovating and training each other, even though we may feel we can't take on one more thing.
Thank you, Suzanne, and thank you, Jody. Suzanne, if I may direct the same question to you. You had mentioned in your intervention the importance of, the challenge of how COVID-19 testing is impacting the lab ecosystem and how it also will eventually affect in the long run. Would you like to elaborate on that?
Yeah, thank you, Shalini. Yeah, so I think it's evident from the 3 presentations today and what we've looked at that there is a great impact that COVID-19 and the testing aspect have had on labs and across multiple other diseases, and it's put a lot of stress on a fragile diagnostic ecosystem. I think that will continue for a relatively long time. There is a backlog there. There are patients that have not been tested, so it will not only have impact on, you know, the timing of that testing, but unfortunately also likely to be affecting the outcome for patients due to this delayed diagnosis. But so if we look at the other side, I think there is also some positives coming out of this. I mean, I don't think you can look to anyone that isn't aware of diagnostic testing right now and the importance of testing. I think COVID-19 have really kind of put testing on the agenda and highlighted, you know, why that is an important part of the ecosystem. And we've seen a lot of creative ways or new agile ways of getting patient tested, being it new test centers being established ad hoc or outreach to patients in different ways, but also just the industry coming together and sharing information in a different way that we've seen before, and taking joint approach to education. So that, I think, is a positive effect that I'm hoping we will see on other areas like cancer moving forward, which certainly will help both the testing landscape, but also eventually patients.
Thank you, Suzanne. And Dan, if I may address the same question to you, you had talked about the importance of establishing and maintaining standard of care for cancer diagnostics. If you'd like to elaborate on that, please.
Yeah, thanks so much, Shalini. So I think that there are two phrases: quality and standardization. So that those two together make standard of care. And when we think about that in diagnostics, we're talking about every patient who has a suspected cancer having a biopsy with a high quality, rapid result that's accurate and includes immunohistochemistry and or molecular if access to those medications are available related to those testing. And that's just a 100% access for all patients everywhere approach that ASCP takes. So when we think about these fragile low-income country systems and where they are now, we have been working in collaboration with more than 80 organizations on building out global oncology and including in that quality and standardization for pathology. But we can step back from that concept in diagnostics and apply that to the entire cancer spectrum. So in prevention, there's quality and standardization of how you approach prevention in screening, in treatment, in palliative care, in survivorship, et cetera, psychological support, nursing. All of these things have quality and standards that we have in the US, we have in Europe. You know, it would be hard to argue that we need to figure out how to treat cancer in Africa. What we need to do is figure out how to transfer the knowledge we already have to treat cancer outside of Africa, for example, to Africa. There are that small number of patients that are certainly benefiting from precision medicine and diagnostics that are growing every day. And as that number grows from 5% to 10% to 20 to maybe even 50% in the next decade, we have to rapidly move that technology to Africa, because we can't wait 20 years for patients in Africa to benefit from these precision medicine things. And I think the way to do that is ensuring quality and standards across the cancer spectrum, including diagnostics.
Thank you, Dan. Thank you very much. I see we have a question from Stephanie. Stephanie, would you like to ask the question? I give you the floor, and it would be great to hear about your experience from Porto Alegre as well.
Yes, thank you, everyone. Good afternoon here in Brazil. So I'm Stephanie. I am city manager from City Cancer Challenge, and we have been working here in Porto Alegre now for 2 years, supporting the city to identify its main challenges and to find solutions. And one of the challenges is to improve the early diagnosis and we have been discussing with city stakeholders the possibility to implement a rapid diagnosis center. So our question here, if our experts in the session know this type of models, and if with the COVID pandemic, if some innovation comes in this sense, that we could support the city to develop an analysis of the ability to have a rapid diagnosis center.
Suzanne, would you like to take the floor? And please, if the other panelists have something to add, that would be great.
Yeah, I mean, I'm not aware of specifically, you know, an analog model here, but I think we've seen a couple of things that, you know, that's worth mentioning. One is the rapid ability to set up alternative test centers or satellite test centers in during the pandemic, and we've seen that both for COVID-19 testing to move it outside the hospitals, but we've seen it also in regards to clinical trial settings. And you know, there's been a lot of effort to not stop clinical trials and to make sure that patient was still recruited and getting on these important trials. And the establishment of telemedicine or, you know, satellite test centers with nurse practitioners who were testing patients and allowing the trials to move forward have been rather successful. I saw some stats lately saying that during the pandemic, actually 87% of all clinical trials have actually moved forward. And also, I think you asked also from a financial perspective, there's been some models around that concluding that if you moved some of this clinical trial testing outside the hospital setting, there is an approximately 25% reduction in cost. So there are some good examples that that we can draw from here and learn from, I think.
Yeah, this is Dan. So I would just add to that. Thank you, Suzanne. I would just add to that, you know, from a practical point of view, if you don't already have it in place, turning to a cytology-based model for rapid diagnostic and assessment and triage of suspected cancer patients for a subset where you can access those tumors with a needle, with or without radiological intervention. That is certainly a way to rapidly assess patients. It won't work for every cancer because of the risks or the location or the suspected tumor, but certainly for breast cancer, skin cancer, lymphomas or leukemias, lymph nodes, anything you can palpate, see, or feel could easily be done in any setting. With radiology, you can actually get pretty deep and do some interesting triage. The alternative approach to that is to look at biomarker-based screening, which is not really ready for prime time. But I think as we look at what's happened with COVID and the impact it has had, that is going to put pressure on that industry for these so-called multi-cancer screening tests to be more available. So think about things like Cologuard for colon cancer screening. Certainly that's not for symptomatic patients, but you can imagine as we think about blood tests or other biomarker-based screening tests, when we think about pandemics, those could play a major role in reducing cost and time and increasing the treatment ability of patients. I would also add that you know, focusing on prevention during a pandemic, as I'm sure Jody will tell you, isn't going to have an immediate impact. However, the long-term benefits of focusing on prevention and that messaging going forward after the pandemic is over can't be downplayed. And so I think anytime you lose your normal services, having a backup plan for your messaging, for example, for prevention is a really good way to boost that going forward.
Thank you, Dan. Thank you very much. Thank you, Suzanne. I also have another question from Rula with regard to breast cancer. Rula, would you like to go ahead and take the floor and ask your question? And that would help me out as well, because I'm not very clear about the question. Rula, would you
Yeah,
like to take the floor?
yes, thank you.
Thank you very much.
This is Rula from Jordan Breast Cancer Program. Actually, I have a question about the guidelines. Is there a global task force for updating the guidelines, especially that they are mainly for mammography screening at the age of 40? Are we considering the Eyebreast, for example, as Jody earlier mentioned that Mozambique have used it? Are we considering it as a modality since it is user friendly and can be used in the outreach activities? I'm not aware of it if it is accepted or recommended by some guidelines. We are adopting NCCN guidelines here in Jordan.
So the Eyebreast exam, or the Eyebreast itself, is still being predominantly used in the clinical trial setting. So it's being used out in communities, but under trial. And I will put that in. I'll put some information into the chat so you all can access that if you're interested in reading some of the information about Eyebreast and how it's being used. The clinical guidelines take a while to catch up to new technologies. So that would take more time, but they are not there yet.
And I would just add, I think, thank you for that question, Rula. I think from the point of view of Eyebreast as a tool, I think what we have to do as a community focused on cancer is recognize that it's just another tool. It has a false positive rate, a false negative rate, et cetera. It is not the same as mammography. It doesn't even have the same role as mammography. It can be valuable for women who have palpable lumps or no lumps at all, et cetera. And so I think the complexity of how you integrate that into a guideline is more challenging than whether or not it's valuable. I think the studies are showing that in certain populations, in the right context, Eyebreast is extremely valuable, especially in the point of care approach or in the low income setting where women can't get to a central hospital for mammography or screening. In certain countries where the average stage of breast cancer is higher, meaning stage 3, stage 4, obviously, you know, that kind of a tool may not be so helpful, but as those programs increase their oncology screening and women downstage into stage 1 and 2, those kind of tools become available for importance in that sector. So I think it's not as simple as importing it into a guideline. It's really stratifying your population and what your epidemiology looks like and deciding which tools, Eyebreast included, would be valuable at this point in your oncology program and how that evolves.
Thank you, Dan. But I have one more thing about that. So it will help in middle and low income countries rather than high income countries, as these low middle income countries use early detection rather than screening. So the Eyebreast would be useful to some extent in these areas.
Absolutely, Ro. That's exactly correct. When you look at, let's just take a random country in Africa where the average stage a woman presents at is say 3.5 of her stage. When that woman comes in, she has a palpable mass. She probably has palpable lymph nodes. In certain countries, the differential is tuberculosis versus advanced cancer. You know, we don't need to image her. We need to do FNA or cytology or a biopsy to just prove her cancer, do her ER, PR, HER2 status, and then get her on treatment. But if we move to another LMIC where the average stage is, say, 1.5 to 2, then women are not necessarily presenting with obvious, you know, suggestive cancers. They may be slightly palpable or not possibly palpable. And so something like Eyebreast for an immediate answer on what's going on with that woman is more important. And so you have to think about public health dollars. If you have mostly stage 3, 3.5 right now, maybe Eyebreast isn't a good investment up front, but it may be crucial in downstaging that population down to 1.5. If you have a country that's at 1.5 or 2 and you add Eyebreast, you're not necessarily going to downstage below that, but you're going to find more women and have a better number of patients detected that can be on therapy. So again, it's specific to the country and how that intervention works. But again, it's a single tool. You have to think about all the tools available and what the epidemiology is and what your goal is. Where do you want to get to? If it's downstaging and decreasing mortality, you have to find everybody and get everyone on treatment. And I think whatever tools will help you do that are fair. I will say, and I think Jody can confirm this, I'm fairly certain Mexico is starting a national program for screening using either Eyebreast or one of the other tools that's similar to that in the same context. So certainly for a country like Mexico, they've done the evaluation and they feel that having that tool out in the community in the hands of healthcare workers will help them with their breast cancer approach. And I think we will see that across other tools like Eyebreast as well.
Right, thanks, Dan. And right, that's right. And I just sent over a link that shows some of the studies from countries to include India. And the other point to consider is what the clinical trials are finding is an increased appreciation and awareness in the patient population for breast cancer screening. So even where mammography was available, culturally it wasn't accepted to go in to get a mammography. Eyebreast is changing those barriers so that patient perspective and how it's shifting the conversation has been really important as a part of the Eyebreast as an example of a new technology.
Thank you, Jody. Thank you, Dan. Thank you, Suzanne. So that brings us to the end of the session. Well, actually almost. Before we close, I'd like to ask our speakers one last question. If you could share just one idea with the audience that would be the most important for them to remember about what we've discussed today, what would that be? Jody, if you'd like to start.
I was just responding to one more question in the chat about lung cancer screening, and it is low dose CT that's used for lung cancer screening, and that is included in the US guidelines. Sorry. Okay.
Perfect. Thank you so much.
So my one thing is to remember that we're talking about people. So we've given you a lot of data today, a lot of information, but fundamentally what we're talking about is people and how they're feeling right now and how we can address what has fundamentally become a psychological issue in many cases where people can get services, they're not doing that. And as Dan mentioned, the prevention aspect and continuing to emphasize the importance of prevention and helping people to continue with prevention behaviors. It's a challenge for all of us, but it's something we have to remember.
Suzanne?
Yeah, thank you. So if I should point out just one thing, it's really the importance of a collaborative approach across stakeholders to improve the diagnostic ecosystem and appreciate the value that early diagnostic testing holds for patients in order to offer them the optimal treatment that everyone will deserve. Thank you.
Dan, please go ahead.
Thank you. So I think the single word I would say is communication, which is an extension of collaboration. You can have multi-stakeholder involvement, and for an individual patient, if the surgeon isn't talking to the pathologist, isn't talking to the nurse, isn't talking to the clinician, that patient is not going to receive the best result. And I think we often find that communication, especially in a pandemic situation, falls apart because there's disinformation and people know what's going on. But cancer care, if anything, is a dialogue. That is what is happening around a patient, is what are we doing for this patient today? What does their journey look like? And that communication and that dialogue has to be informed by every member of the team. And so I think that is a really crucial piece that we have to continue to do as we keep the patient at the center of this cancer approach.
Thank you very much, speakers. Thank you for all those really important takeaway messages. With that, I'd also like to thank the audience for your time today. This was really a good discussion, and I wish you all a really good day or evening. And bye, everyone. Thank you for your time. Bye-bye.